Good afternoon, everyone, and I thank you all for joining us this afternoon. It's great to seeing you introduce yourselves in the chat box, so if you haven't already done that, please continue. I'm Beth Stroll with the TA Network for Children's Behavioral Health, and I'd like to welcome you to this month's webinar. This session is part of the System of Care Leadership Learning Community. Denise Silsback and I facilitate the learning community. We hold it monthly, and it's designed to support leaders in systems of care, so that could be in states, tribes, communities, and territories, and it includes those both with and without federal grants. So we try to make these sessions relevant for all types of jurisdictions. It's designed for leaders with many roles in systems of care, including those in director roles as well as leaders in various content areas. We do try to address topics that are important and helpful to you in your work, and we always welcome your suggestions for future topics, so please feel free to reach out to us. This year we're focusing most of our sessions on operationalizing various elements of the system of care approach, and today's session will focus on implementing a continuum of crisis services with a special emphasis on including mobile crisis and response stabilization services. We do like these sessions to be as interactive as possible, so we encourage you to put your questions, comments, insights in the chat box throughout the session, and we've incorporated time for questions and answers. Denise and I will make sure that any questions you enter in the chat box are addressed. If we end up with a small enough group, we will also open a line so that we can have a verbal conversation as well, and you can ask your questions that way. Just below the chat box, you'll see a box that will allow you to download today's PowerPoint presentation. And also as a follow-up to this session, you'll receive a link to the recording of the webinar. And at the end of the session, a link will pop up for a very brief evaluation survey. And we would very much appreciate your taking just a couple of minutes before logging out to complete this and provide us with your feedback. We do take it very seriously, and we do use it to improve our future learning community sessions. I'd like to take just a moment to mention our learning management system that we call Ideas at the Institutes. This is a platform that allows our learning communities to be more user-friendly and more interactive. It's a digital hub. You can join various learning communities that we offer. You can register for webinars. You can find resources and recordings of previous webinars, and you can interact with experts and peers. And the link to sign up for that is on this slide. Here you can see what you would see when you log in and where you can find information about the learning communities. So we do encourage you and your staff and partners to sign up and take advantage of the IDEA system. We're really very excited about all that it has to offer, and we're seeing more and more people join us for that. Before we get to the presenters, I'd also like to mention the training institutes. Registration is open for the University of Maryland 2020 National Training Institutes that will take place next summer in Orlando, Florida. There will be pre-institutes training programs on June 29th and 30th, and the institutes themselves will take place from the afternoon of June 30th through July 3rd. We have been encouraging states and communities to budget for this and bring a delegation to the institutes, and we do hope to see you in Orlando. I wanted to let you know that we're monitoring the coronavirus situation very carefully, and we will be providing regular updates about that, but we are planning to move ahead with the institutes and really encourage you to think about joining us for that. Also, the next learning community session in April will focus on serving youth with co-occurring substance use and mental health conditions. And it'll cover both treatment issues and system-level issues like policy and financing and such. So we hope you'll put this on your calendar and join us then. I believe it's April 19th. Tiara, our wonderful tech expert, will put a link to register that, or it looks like she already has, in the chat box, and you will get a link also in the follow-up email that you receive from this webinar. And as always, you can find information about upcoming technical assistance opportunities in the weekly TA telegram. So again, today's session will focus on crisis services, and we are very fortunate to have two outstanding presenters. From our own TA network, we have Liz Manley, who is our leading expert in many areas and has done extensive work on crisis services. She was formerly an assistant commissioner in New Jersey, where she led the statewide system of care, including the implementation of mobile crisis services statewide. So she has a lot to offer about comprehensive crisis systems and mobile crisis in particular. And then we have Ann Polakowski, who is the clinical program manager at the Nevada Department of Child and Family Services. And Ann will provide an example of mobile crisis services in Nevada and the results that have been achieved there. I'd like to thank Liz and Ann for their great work in pulling this session together. The objectives of today's webinar are to overall provide guidance for implementing crisis services for young people, and specifically to review the goals and components of a crisis continuum, and to provide guidance for implementing that, as well as mobile response and stabilization services. So now I will turn this over to Liz, who will get us started. Liz?
Thanks, Beth. So I'm really honored today to talk about why a children's crisis continuum is really important within the context of systems reform and in the context of systems of care. I mean, one of the underlying principles of this work is to address the sense of urgency that families feel that drive them into care in the first place, and how do you actually get to them really early. So I'm really happy about this particular conversation. And so the first question is, why crisis continuum care specifically for children? A lot of folks think that building a crisis continuum across the lifespan makes sense, and it does, but it requires some specialty care and specialty thought around what children and families require in order for their needs to be met. And so a crisis continuum of care designed specifically to meet the needs of children, youth, and young adults and their parents and caregivers is necessary, because we're not just trying to de-escalate a situation that happens right now. We're trying to ameliorate a crisis before more restrictive and costly interventions become necessary. In other words, the adults that are surrounding the child actually see changes in the child and see what's happening well in advance, and generally speaking are able to say, we saw that coming and couldn't we have prevented it. And so a crisis continuum is designed not only to address what they see for children, but they see for that surrounding support systems. So the key services is to shift from the overuse of those high-end services like an emergency department and inpatient units for children who don't require them. In 2018, we published a paper for NASHBIT that made the case for building a children's crisis continuum of care, and a lot of this presentation is really about how we went about putting that together and why that whole conversation was really important to have a specific crisis continuum for children. A lot of states these days are really addressing the challenge of having more and more youth enter emergency departments in order to get what some states would say is really primary care for behavioral health. And the goal of all of this discussion today is really about how do we move that front door from an emergency department really to a more responsive service for children and families. And it also allows us to really have a conversation about the evidence-based home and community services and the whole continuum in the service array, allowable both from CMS and from and as supported by SAMHSA. So the beginning part of this conversation started with the idea that we were challenged because there were a lot of states who were really seeing an increase in the youth visiting emergency departments. And some of the data suggested that we really needed to be attentive to that. As you can see, there was a big increase from in the use of emergency departments from 2001 to 2010. But what was interesting is that there were states that were bending that curve and seeing a decrease in the overutilization of those emergency departments. And so we really wanted to take a look at those. The ED usage rates for publicly insured kids without any health insurance are fourfold above those that are privately insured. So when states consider these and communities consider the use of some of these services and supports, they really need to be attentive to the idea that it has to be insurance blind. You really need to, if you want to bend the curve, you really have to be attentive to the idea of who it is that's using those emergency departments and why. And EDs are not the right place to serve children who are in the highest level of crisis or in a crisis period because they lack, generally speaking, they lack expertise to respond specifically to pediatric psychiatric emergencies. And some lead to boarding, which is when a youth is in a hospital bed but not receiving any care. It's expensive, it's not effective, and it's time-consuming and frustrating for families when they have to experience those conditions. So we're looking for better outcomes in both the cost and quality of care, and we know that we can achieve them through community-based services and supports, and it really requires us to redefine the word crisis and who defines that crisis and what it looks like in order to address a lot of these real challenges that folks are experiencing. So the infrastructure that we've come to conclude really is important for folks to consider is, first of all, a single point of access certainly is makes it really easy for youth and families to access care if they only have one phone number that they have to call and care is provided. That's certainly the model in New Jersey, and some other states are looking at that or considering that. Single point of access is a really a great driver in terms of addressing both stigma and some of the challenges that families have in trying to connect to care. A no wrong door approach means that we've trained everyone in the community to call a particular place when they need to access care, so that everyone is trained. So even if you don't have a single point of access, if you get to all of the places in which children and families access care and you bring them into the discussion, it can be really effective in not having families feel so very frustrated and trying to reach out. A crisis hotline is a great idea and has a lot of, there's a lot of support around crisis hotlines across the country, and there's been some success in that. Electronic health record and having a single electronic health record is certainly something you want to consider as you're thinking about this work. It's a really thorough triage process that both is engaging for families and with a focus of engagement for families is important, but also an understanding of what is driving the call for that youth and family that day. Mobile response and stabilization, which we'll talk about in more detail, which is a really important part of any transformation within a behavioral health system. A clear assessment and assessment process that allows everyone to be assessed from the same perspective. Crisis intervention and initial identification of what's driving the underlying behavior, and certainly crisis stabilization, residential crisis stabilization beds in places in which that's necessary, and certainly recovery and reintegration are all parts of the work that we're talking about today. Strategies for encouraging coordination and collaboration include the co-location of partners in the community. So what that might look like, certainly what it looks like in New Jersey is a mobile response team might outpost a team to a particularly rural part of a community by using shared office space and shared tools. The use of crisis text line and warm lines and suicide hotlines and connecting those things so that they all connect to each other and are partners within the context of the work is really important. And certainly the use of paraprofessionals and peer support within the work is important. System coordination and community collaboration is really one of the drivers of change. So in other words, you want everybody on the same page. You want everybody working from the same place. You want primary care and psychiatric care providers talking to each other and working together unique to really address challenges within the child welfare system, challenges around youth going into foster care, youth touching on behavioral health services through the child welfare system. You want really good inter-coordination because you don't want families to have to touch on child welfare in order to access care. Really important part of work. You want law enforcement to have tools to be able to engage youth and families and not use things like juvenile detention centers in order for them to address the community safety concerns that they would bring. You want good connection to care in schools and having them be able to bridge what happens during the school day to the home. You certainly want engagement in emergency departments, juvenile justice and family courts, and community organizations. These are all the important partners in the work in working with children. What's important about this is also that these are not necessarily partners that exist within the adult world in crisis, when crisis happens in the adult world. And when you have adult professionals who are working with children, they don't always take these things into consideration, and they're all imperative in the work with children. In 2013, CMS and SAMHSA put together a joint informational bulletin that described home and community-based services that were really important to address the needs for children with complex needs. That service array included mobile crisis response and stabilization. We took the word crisis out of that work because crisis really sometimes confuses both professionals and families on when to use this service. It names several services critical to developing high-quality crisis continuum, including mobile response and stabilization and residential crisis stabilization beds. So, in other words, CMS and SAMHSA have identified what really would be helpful within the context of a crisis continuum of care for children. And defining and implementing a national standard for crisis care, it helped us really be able to identify what was really necessary in the context of some of this work. So why adult versus child, why a child mobile response team and versus an adult mobile crisis model? First of all, children and youth are developmentally different and require different approaches. What drives the underlying behavior for children is really, and can be really different than what drives the underlying behaviors for adults. Parents and caregivers often see changes in those children early and know that it's coming, but they just don't know what to do about it, and they don't know how to reach out for help. It's also important to recognize that for many families, this is the first touch on a public system, and that first touch really needs to be responsive because we want parents and caregivers to use the system effectively in the future. Children and youth are connected to different systems, and those systems are really important partners in this work. And a responsive intervention to children and families can be less stigmatizing for children and parent and caregivers. So in other words, it's individualized and meets their needs up front, and it's responsive at the time that the family reaches out for help. The reality that the family will use those services and supports again in the future becomes more real. So why mobile response in a crisis continuum? Because mobile response and stabilization is an upstream intervention that gets to youth at the time that they're beginning to experience what is the beginning of change for them. Children and youth and young adults and families can initiate care based on a self-defined crisis. In other words, when a family calls for help, they're defining the crisis, not the professionals who are answering the phone. Because the parent is defining the crisis, and we accept that definition of crisis, because the parent picked up the phone and called the public mental health system, we recognize that they need help and we send it. That responsiveness is important in changing the perspective of what families might think is a non-responsive system. Engaging families in a cultural and linguistic competent crisis response is essential, not just for reducing the risk in the current crisis, but preventing future crises, and also building a trust for the system. And what it does is it really helps families understand that you can use mobile response and stabilization as the go-to rather than an emergency department. If a family goes to an emergency department to get help the first time, they will continue to use that emergency department in the future. If they use mobile response and stabilization, and it's an effective intervention, then they'll use mobile response and stabilization again. The value of mobile response within a continuum of care means that you can effectively de-escalate, stabilize, and improve the treatment outcomes for children. And we've seen this, and we know this. We've seen that certainly in New Jersey and in states like Connecticut, Oklahoma, and Anne's going to talk about Nevada. It's designed to intercede upstream before urgent behavioral health situations become unmanageable. And really there's a period of time in which we know things are happening and changes are occurring, and that is the time in which we want intervention to happen. The other thing that it does is it allows families to have energy to deal with the changes that are necessary to address the needs of their children. They're not so tired because the crisis has gone on for 2 years before they've gotten effective intervention. It keeps children, youth, and young adults safe in their homes, in their communities, in their schools whenever possible. And that's where youth get better, and they get better the quickest period of time is in their own homes. And we look for viable alternatives to acute care and residential treatment because they consistently demonstrate cost savings while simultaneously improving outcomes and achieving higher family satisfaction. So mobile response mission and goal is really to help youth and their families that are experiencing emotional and behavioral stressor by interrupting the family-defined crisis and ensuring youth and families are safe and supported. Mobile response and stabilization provides on-site assessment, intervention, support, and skill building necessary to stabilize the youth's behavior towards improvement in functioning and living situation and stability. In other words, it's right where the family needs it. It's in their home or in their community, and it allows us to get to what the underlying driver is for why that family made the call that day. Mobile response collaborates across the whole youth serving system to support youth and families, and they engage and coordinate supports that help youth and families become safe, healthy, and connected. And what's really important about that is not every child needs a clinical intervention in order for them to feel better and to be re-engaged in the work. And mobile response and stabilization helps sort out that, helps sort out what children will benefit from an outpatient intervention and what children aren't quite ready for that outpatient intervention. But it allows for the reconnection and the community supports that are so important. As an example, reconnecting a youth who might have gotten kicked off of activity like football or got suspended from the ability to engage in their favorite activity. And mobile response has the capacity to be able to go in and figure that out, figure out what happened, and help those youth reconnect to what's important. Mobile response is an important part of a continuum of care. It's not the only thing within the crisis continuum of care for children. It's just an important component and a foundational element within systems of care. It can effectively de-escalate, stabilize, and improve treatment outcomes, and are specifically designed to intercede before urgent behavioral situations become unmanageable. It doesn't mean that every child, you'll keep every child out of the emergency department, but you certainly reduce the use of emergency department and inpatient care dramatically when it sits within your crisis continuum of care. So what are the core components? The folks who've been doing work in this area for a long time have come to conclude that these are the core elements, that it's home and community-based, and that it is face-to-face. Every call that comes in requires a face-to-face on-site therapeutic response. Really important. So we don't determine that this crisis isn't escalated enough. We actually, when you get a call, you move. And when you get there, the goal is to de-escalate, find the ability for the youth to communicate, understand how they communicate, both when they're doing well and when they're not doing well, and help families be able to reestablish those communication patterns. 24/7 access is imperative, and so is the ability to do a comprehensive assessment, to provide crisis intervention support and stabilization. The capacity to do psychiatric consultation and connect to psychiatric consultation when appropriate is really important, and to know when that appropriateness is. When is that necessary? Recognizing that it's not necessary for every child. Referrals and linkages to services and supports, both informal and formal supports, is important. And the capacity to deal with the psychopharmacology challenges that might be. And that crisis is always defined by the caller, always. It's not debatable. You'll see we said that twice because we think it's the most important part of the driver, and these are just really important common elements that are really necessary in order for mobile response to be mobile response. You want to build on natural support structures like additional family members and bringing them to the table, how to engaging in the schools and the communities that the children live in order for there to be long-term connections that are so important when children are experiencing some behavioral challenges. And some considerations for implementation include local organization within the system of care structure. In other words, you don't want to build mobile response and stabilization independent to other systems reform. It's connected to other reforms. If you're doing work on Family First and want to use a service like mobile response, you want that to be connected not just for children in child welfare. You want it to be insurance blind and connected to all children in a real public health model. There are places to start in terms of that work, and it's just really important to think about how to connect those dots. You need a provider network, not just to the providers who are going to provide mobile response and stabilization, but the ability to connect to the services and supports that are necessary in order for you to get the care that they need. We need connection to family support, and that's peer support, which is really important. And in some states like Oklahoma, peer support is part of the response team. It's really important to take into consideration in this work. You want to really think about your staffing model. Whether you use bachelor's prepared folks or clinicians, depending on what your workforce looks like in your communities. It's really important to be attentive to what you can accomplish. New Jersey uses bachelor's prepared folks who are very well trained and certified in order to get the work done. It addressed a lot of the workforce challenges that New Jersey had in the beginning parts of the work. Training, certification, and supervision are incredibly important, need to be built in the model, not just in the short term, but in the long term. They have to be always part of the process for mobile response and stabilization and should be embedded in the whole work and shift in the work. State and local systems of care have to be able to come together to support the work, recognizing that this is a core element in systems reform that addresses the urgency that families feel that is so important in systems reform. Other strategies include telehealth and co-location of workers, satellite locations, and broad-based teaming are all part of it. Use of technology continues to improve and really should be part of the conversation when you're building mobile response and stabilization and workforce strategies across the continuum of care. So time to talk about money and how to finance a crisis continuum of care. So some potential sources include Medicaid. As I said, in 2013, CMS and SAMHSA were supportive of children's crisis services being built into a system of care and using Medicaid to do that. Certainly you can connect commercial insurance plans. The use of a service like mobile response and stabilization reduces the over-reliance on emergency departments and inpatient care, which are much more expensive than a service like mobile response and stabilization. Local and state educational funds, child welfare, mental health in general, state general funds, and federal grants are all part of a continuum of how you build a financing structure that works. You do want to build a financing structure that has long-term ability to sustain the services and the need for the ongoing education and support for folks. You need strategies to build a continuum to include braided and blending funding whenever necessary and reprioritizing where funds are used. So in other words, you want to be nimble enough to move resources when they need to get moved in order to continue to build capacity or to address capacity issues as they shift and change. States and localities may elect to blend and braid to address the needs of children, youth, and young adults. So in other words, there are other places that you can look for funding as necessary. Braided or pooled funding precludes the ability to report. So blended funding means that the funding actually is really in one pool. It makes it difficult to figure out whose fund is what and what things were paid for. Funders must accept reports on services provided across the population served rather than the services provided to specific children and youth and the stream of funding dollars. So it's important consideration when you think about how you're going to pay for some of this. Federal and state statutes prohibit the blending of some of those funds, so you have to be attentive to where those dollars are coming from, but certainly it's possible to blend these dollars. Braided funding means that they're coming together, and you can actually you can track where those services are paid for. Streamlined service provision by eliminating the need for individuals to enter separate programs to obtain each component identified in a single care plan. So there are places in which braided funding makes sense. There are places in which blended funding makes sense, and that all has to be taken into consideration in terms of the federal dollars that you're pulling down and how they all come together. But these are all considerations that come into place once you've made a decision about including a service like mobile response and stabilization or the other services within the crisis continuum as we've outlined and talked about today. Some examples of cost savings include Connecticut and the evaluation of the state's emergency mobile psychiatric services found that in 2014 the average cost of an inpatient stay for Medicaid enrolled child and youth was $13,320, while the cost of mobile response and stabilization was $1,000, and that's savings of $12,320 per youth. So really understanding that mobile response and stabilization in that upstream world can actually prevent not only the escalation for youth, but actually you can find cost savings because you're getting there earlier. In 2013, the EDs referred to emergency mobile psychiatric services 1,121 times, and 553 of those referrals were coded as inpatient. So this is how they know that they were able to really avoid and divert youth from the inpatient, from the emergency department into mobile response and stabilization. In King County, Washington, there were great success in terms of the use of the Children's Crisis Outreach Response System. That continues to be true. They continue to be using the services to support youth, and their cost savings have been quite significant over time. The same thing with Pima County in Arizona, and the work in Texas. So we haven't even talked about some of the other places that have done such great work in really moving mobile response and stabilization to the forefront. One quick example in New Jersey. New Jersey has over a 15-year history of using mobile response and stabilization, and what we do know is that the majority of the time, so 96% on average, the youth stays in the first place that they are, so that they never move from their home or the foster home in which they've gone into. So since its inception in 2014. So it's really important to keep that in mind. This is just the trend. I always think that this is an interesting trend because it tells you that the service is used really pretty consistently over time. Even when you increase the number of individuals who are served by the service, they still have lulls in the summer because education partners are really important partners within the context of this work. And then the impact in New Jersey for sure is impacted on the residential interventions that have gone into place. And this chart really just shows you the decrease over-reliance on residential interventions specifically. And I can update you that the data continues to go down. And as of February of 2020, there was 931 children who were in a residential intervention in New Jersey, according to their own public data. All right, I'm going to hand it over to Ann.
Thank you so much, Liz. Ann, are you muted?
It looks like we may have lost Ann on the phone, so let's give her a couple of moments to get connected again.
Okay. Okay.
So
In the meantime,
this
Liz,
is me.
Oh, go ahead, Denise.
Yeah, no, I have a question for Liz. Liz, you
Sure.
You spoke a little bit about the use of crisis response, or mobile response and stabilization for the foster care population in New Jersey. Can you talk a
Yeah.
little bit more about that, especially the pilot project that you did where you sent the response team
Yes.
out when youth were being placed in foster care?
Yes, I can. Thanks for that question. So we did a little research in New Jersey and recognized that children going into the foster care system had an average of 6 moves before they touched on the behavioral health system, and almost all of them then required a really high intervention like a residential intervention. And so we wanted to stem that tide and recognize that if we could use mobile response and stabilization as a tool, we might be able to actually be effective in keeping children in foster care. And so we did a pilot in one particular county in which we worked with the child welfare system and required that every child going into foster care who are removed from their home and going into foster care because of concerns of abuse and neglect over the age of 4, so we included 4-year-olds in this conversation, a mobile response team would meet them at the foster home and have a simple conversation with them. The conversation was very simple. Something big just happened to you. Because something big just happened to you, you might have a hard time eating, sleeping, paying attention. School might feel different. Happens to some children. Doesn't happen to all. But if it happens to you, we know what to do about it, and we can help you through that. We can be back here in an hour to help you through that. And they turn to the foster parent and have the same really important conversation. Something big just happened to this child. Because of that, they might have a hard time eating, sleeping, paying attention. School might feel different. And from that, we were able to keep 46 out of 46 youth who went into foster care for the, in their first bed that they went in. They stayed in that first foster home with 0 behavioral moves. Many of them got connected to wraparound and intensive care coordination, and we had a broader care plan in place for them that included both formal and informal supports. But none of them moved from the initial foster home that they went into because of behavioral need to move them. Some went home, some went into kinship care, and with that, they took teams with them, so the teams were able to move with them. So it was pretty powerful, so powerful that the rest of the child welfare system in New Jersey, the other 20 counties, wanted it. They wanted it immediately. It's currently in policy in New Jersey, and it is one of the contributing factors to those numbers in the residential interventions going down so significantly.
That's great, Liz.
Thanks. It looks like we got Ann back, so let's turn it over to her to talk about Nevada's crisis response system. So Ann, go right ahead.
Good afternoon, and my apologies. I put my headset on so you all could hear me, and I disconnected, so I apologize for that. I'm Ann Polakowski. I'm a program manager responsible for the mobile response and stabilization team in Nevada. We are 6 years old now, so I can no longer say that we are in our infancy stage, but we continue to develop and change and grow over time as more people become familiar with mobile and are starting to utilize mobile services. So mobile started in 2014 in Nevada in response to a crisis that we were having in our emergency departments, where adults and youth were utilizing emergency departments as a way to seek behavioral health treatment. So we started mobile response, and initially we were responding mostly to emergency rooms and to schools. Those were our first champions, our first ports of entry into this service, and we are now getting calls from just about everywhere. So community providers, parents, which is fantastic. We really worked hard to get word out to parents directly that they could contact us. And we really want to move away from responding to children in emergency departments as the first line of where families are seeking that support when their children are experiencing a behavioral or a psychiatric crisis. So that was our initial goal, was to support those emergency departments, facilitate short-term hospitalizations when necessary, which happens to about 14-15% of the time at this point, and that has stayed pretty steady over time in terms of the numbers that we need to put into a short-term acute psychiatric for their safety and for stabilization purposes. About 85% of the time we're able to stabilize in an outpatient and intensive mobile response setting, and I will get to that. And like New Jersey, we are also doing things like linking to ongoing supports and really getting that family connected with services for long-term therapy, long-term case management resources, those kinds of things. We also are working under the philosophy of crisis is defined by the caller. If you are new to mobile response, this is an interesting philosophy. It takes some training of staff and the community to understand that crisis is defined by the caller and that we as mental health people are not defining what would be a behavioral health or a psychiatric emergency or crisis for a youth, but that really is coming from the caller, from the caregivers. We did find that we had some drift here in Nevada as leadership in 2 different regions. I was running one region and another region was being run by somebody else, and that other region had some drift where the crisis started to be defined by the mobile response staff and less by the caller. And about a year ago, I took over that region as well, and we worked with staff. We re-educated our mobile response teams and the community. And what we've seen since we have shifted back into the model as it was intended to be is a significant increase in calls back to the hotline from the community with things that wouldn't have been defined as quote-unquote crisis a few years ago when staff was defining that crisis. So that's really been a fantastic shift and away from that drift and coming back into the model since we have redefined that. What we've also seen is we're responding to more youth in the community there, and we are now having a demand from the community to expand our services and to get more teams in that region. So the community is really responding to this. So we really want to meet families where they are, to respond in the communities, and to ensure that we can come up with a safety plan that's going to support this youth and this family, both in the immediate needs and in the long term. In Nevada, rural mobile crisis is part of our mobile team, but it looks a little bit different, and we will talk about that in just a minute. But we are at this point getting calls from all 17 counties in Nevada, so that is very exciting for us. Nevada is a really large geographic area, so in the rurals we are utilizing telehealth to get to our families quickly. Most of our youth coming in are still coming in for suicidal ideation, a suicidal statement, some suicidal behavior or self-harming behavior, parent-child conflict, some homicidal physical aggression, reactions to abuse, trauma. So we are getting quite a variety of calls, but the most significant call at this time still is surrounding some suicidal ideation. So how it works here in Nevada is that the call comes into the hotline. This is another shift that we had in Nevada recently, moving from 2 different hotlines to 1 hotline. So now all calls come through 1 hotline and are answered by the staff in Las Vegas for the entire state at this point. There has been a little bit of pushback from Reno, and the concern being that we don't understand that community, so we are working on that right now to better understand the community and to also inform the community that what we really want to do is respond. So you call and I send out a Reno team who does then understand the community, and that's really what is important at this point. We gather some initial information on the presenting issue. We ask some safety questions, and then we go. We don't want to spend a lot of time on that call, enough to get the information we need and to dispatch our team out. Sometimes we do provide support or resources. We do get a lot of calls for resources, hard resources like food, electric bills, that kind of thing, and then calls also for dispatching. When we go, we send out a team of 2. So we send a master's level clinician and a bachelor's level psychiatric caseworker. And we respond in the family's location of choice. So unless they're in the emergency department and the doctor is saying you can't leave here, you have to have your response here, we are responding when and where the family would like us to respond. So for some of our families, that might be a few-hour delay because they're at work and they would like us to come when they get off work. But our commitment to the community is that if you call, we will be there within the hour if that's what works for you and your family. Some of our families would like to come into our office, so that is an option. In Las Vegas in particular, we have a good number of families that have some transient housing, might be staying in a weekly or staying in housing with other families with other family members or friends, and they just don't find that that's private enough for us to come in, so they will come to the office or we will meet them somewhere else. We perform a structured assessment, a structured clinical assessment called a crisis assessment tool. It's elements from the CANS, so it's a shortened version of the CANS. And we also do a crisis needs assessment where we are looking not only at the clinical presentation, but all of the supports, all of the strengths, and any needs that that family might have that we can help support, like food, housing, paying of an electric bill, those kinds of things that are additional stressors on that family to help alleviate that stressor so that they can help then support the youth that we have gone out to see. And then if hospitalization is needed for youth safety, we do work with our local hospitals to get that youth into an acute setting. Following mobile response, we want to meet with that family again in 24 to 48 hours at the latest if the family is interested in engaging in stabilization services. Most of our families do choose that option. Many of our families, like Liz mentioned, this is their first touch or their first entry into the mental health system, so they aren't connected yet with resources. So a lot of our families will come in for 30 to 45 days. We will work on those skills that Liz talked about, opening that communication, continuing to stabilize that initial crisis that they're coming in with, and the linking then to ongoing resources. Some of our families have resources already, but there could be a gap. They may not be able to see their therapist for a couple of weeks, and we can go in and provide that stabilization and that support to fill that gap for them. And then some of our families come in and they are totally wrapped, completely connected, and we just make sure to connect with their provider, let them know what has gone on, and provide that handoff back to their provider. So we just, at the end of every response, we complete a safety plan. And in that safety plan, we really are looking at what are some of the triggers for this youth so that everybody involved in this youth will know what are the triggers, what are some things that they can do themselves and that their support system can do to help when they are feeling triggered or when they feel like they need additional support. We list phone numbers, we list activities, and we provide this to every youth regardless of the outcome. So regardless of if they're going into the hospital or stabilization or going back to their provider, we complete the safety plan. If they stay in stabilization with us for that 30 to 45 days, we are continuing to revise, to enhance, to add things to the safety plan so that when we leave, they have a really robust plan on ways that they can support themselves and support their child when we are no longer involved in that family. Rural response looks the same in that the call comes in, it's defined by the caller, but then we send it to our rural teams who are all working by telehealth remotely and who can connect with that family within about 5 or 10 minutes using a video platform called VSEE, V-S-E-E. It is free to the families, so they download the app. The clinician who calls them talks them through how to get connected using this platform, and then both the assessment and any ongoing stabilization that happens all through this telehealth platform. And rules always like for me to give you a visual of what that looks like, both on the clinical side and on the family side. It is HIPAA compliant as well. I already hit on this. I do this a lot where I talk ahead, and I apologize for that. So multiple options for safety that we talked about. The majority are still referred then to ongoing stabilization services while we get them hooked up with long-term. We're very connected with our family support partners. So Nevada PEP is one of our is our family support partner, where most of our families will then go to receive that peer support. Primary referral sources, emergency departments still continue to send us and call us on a lot of youth. We have had schools, community partners, as I talked about earlier. Something has happened in Nevada in our last legislative session where our Legal 2000 process, our involuntary hold process for youth changed. So in the past, only Las Vegas was really accessing this involuntary hold, and now the entire state is aware that this can be used for youth as well. So there's been a lot of conversations here in Nevada about what this looks like for youth, this involuntary hold process. School districts are having to write policies surrounding that, and what went into the law and what went into the school district procedures is they are supposed to contact mobile response before they initiate this involuntary hold on youth. It's been rocky, but we are continuing to have conversations on that. And I think it's fantastic that we have that in the law, that they're supposed to contact mobile response before they can initiate that involuntary hold. So that's a work in progress for the next time we all talk. Staffing, we have supervisors, mental health counselors or clinical social workers, or clinicians. AAs, we have an intake coordinator in a couple of regions and some psychologists on staff. We do have access to psychiatric care as well, where we can get youth in, especially in Reno, within a couple of days for psychiatric care, which really does help with being able to keep kids safe in the community instead of having to put them in the hospital for that psychiatric care. Funding in Nevada, we have some Braided Funding funding as well. We have funding coming from our Helping Nevada, which is our tobacco settlement funding, some state general funding, and then we are able to bill Medicaid and some block grant funding to fill in some of those gaps as well. In the rural, they were started and funded initially through our System of Care expansion grant, and then in 2020 fiscal year, they were able to sustain by accessing the Healthy Nevada funds as well. And that's just a breakdown so you can see about where our insurances are coming from. A lot of uninsured youth are accessing our services, as well as the Medicaid and the public funded insurance plans. We do take any youth who calls regardless of insurance status. So whether they have Medicaid or other public funding, private insurance, or no insurance, we are able to see all those youth. Our staff are very well trained in a wide variety of training, to include all these here, motivational interviewing, system of care. We do a lot of formal trainings with our staff, and then a lot of live training, shadowing, and coaching. So new staff come in, we do that formal training piece, we send them out with our teams to see how it works. Then they do it while they're shadowed, and then they are able to go out on their own. So for some staff that may take a month or two for us to have them out on their own, but it's really, really important that they're understanding the process and the model before we release them on their own. There's a good amount of clinical oversight that we provide to our teams. This is really hard work. We see really intense youth and families, and it moves very, very fast. So we want to make sure that we're able to provide them support and some oversight. So we provide the support on the hotline calls. After every hotline call that ends in a response, they come to a supervisor. They say, hey, we got this call. We assign a team. We know what teams are coming out. We are signing off on the intervention screenings. And for calls that don't end up in a response, we're looking at why that might be to make sure that we haven't lost any youth or families. We aren't losing them in any gaps that we might have. After a team has gone out and done the assessment, before they can leave that assessment, they then call back and talk to a supervisor, give a little rundown of what happened in their disposition and their recommendation, and then they get supervisor approval to do that as well. We do have a lot of interns, which is part of the reason for this high level of oversight, is we have master's levels clinicians who are working on getting licensed. So we want to make sure that we are both providing them the support they need and making sure that youth and families are safe in getting what they need out of our responses. Some of our quality measures, we do some follow-up questionnaires at a week and then again 3 months and 6 months out. We are using some evidence-based practices in mobile response, live supervision and coaching, and then clinical oversight that I just talked about. And then we do keep track of things like demographics, our calls, how long are we on the calls, how long does it take us to respond out in the field, numbers of youth that are stabilized in the community, which is really our goal, versus the number of youth that we put in the hospital for safety reasons. Who is referring, who's not referring is actually a big one for us, so that we can make sure that they understand what our services are and how we can support them in keeping you safe. We look at, did we ensure safety and how? Were we able to connect to resources, and if not, why, so that we can fix that gap? We look at the changes in the CAT from beginning, from our response to our end discharge, and then again the client satisfaction that happens at the end of treatment. Some of our collaboration partners and champions, as mentioned, we're looking at our parents, neighbors, families, our informal supports. Our consortia are very big in helping to support mobile response. Hospitals have always been on board with us and really do access our service. School districts depends on the district. So in Clark County and Las Vegas, the school district has been very active, also now in Reno, and we're really trying to engage the school districts on how to utilize us earlier than when that youth is right sitting on that point of an involuntary hold. So we're going to get there as this involuntary hold takes place. Law enforcement is a tricky one for us. It's hard to engage law enforcement here because they want to move on to the next call, is the conversations that we're having. And so how do we really slow that down and have law enforcement engage us earlier when they're called out on a call? And then our faith-based and community organizations are partners for us. Some of the expansions that we're doing, we're looking at how we can transition youth as they come out of higher levels of care and back into the community with our intensive mobile response services, especially the stabilization services. How do we support that transition out for that first week, for the first couple of weeks until that youth is reintegrated into that family, and we've got all those other services connected. When kids come out of higher level of care, they don't necessarily get into those supports the next day. So we want to be able to support that. We've got a lot of work to do still surrounding the involuntary holds. We did centralize the crisis line since I last updated that slide, and we've had a lot of success with that. Rural use telehealth, telemedicine. We are looking at how to get those in Clark County and Washoe County as well to support the hours that other regions are not open. So Las Vegas is open 24/7. Our teams in Las Vegas are, but the rest of the state are not. So we are trying to figure out how we can use the telehealth here in Clark County to support the rurals, the frontiers, and Reno after hours and on the weekends. And then there's an ongoing conversation about crisis. And do we keep crisis in our mobile response name, or do we take it out? So right now we are the mobile crisis response team, and people who are pros of keeping it in like the crisis in there. The con, of course, is that people are wondering if their call rises to the level of crisis. So mobile crisis is defined by the caller is too long, so we're trying to figure out how we educate everybody that crisis is your crisis, not something that would necessarily be crisis by a traditional definition. We gave you a copy of what our safety plan looks like so you can see what we are doing when we're working with that family and that youth to identify some triggers. Some unique questions that we have is how can we make that environment safe for the youth? We ask the youth, what can your parent or caregiver do to help you? And what is the most important, what is one thing that is important to me and worth living for? And we have found that to be a very powerful question with our youth, and to be able to document that on here is very important for us. That's it. That's how you can find us if you're interested in learning more about mobile in Nevada.
Great. Thank you, Anne. So this is Denise, and we do have a few questions and comments. First, Proud Growth in Virginia, who did share with the team in a comment box that in Virginia, they have family assessment and planning teams where representatives from various disciplines get together once or twice a month, review cases presented, and they are able to use human service funds to pay for services for families in need. So I can see how that could be connected well with a mobile response system. He did later talk about or comment about relationships and working with the police, and I'm scrolling down to get his language. Really, in theory, it sounds like a great idea to be partnering with law enforcement, but sometimes there are negative results in interactions with persons with mental illness. So he's interested in knowing what type of training you are using in Nevada and New Jersey. He's heard of the use of crisis intervention teams, CIT officers, and really interested in what else is out there and what you see as being successful.
So this is Liz, so I'll take New Jersey first. So the issue of law enforcement can be really challenging, and so I do want to clarify that law enforcement are not part of the response team, right? So this is law enforcement coming across a youth who they're concerned about for some reason or another, and what do they do, right? This is not the mobile team calling for a response, and there's a particular reason why we don't use law enforcement for those first responders. First of all, it's not necessary. We've never found a situation in which that we regretted not going in with law enforcement. And secondly, that's not their role, right? Their role is something different. But the mobile response teams in New Jersey actually train law enforcement on a regular basis around how to use mobile response. How do you call, when to call, how do you talk to parents about it? And even in the early days, they handed law enforcement, every law enforcement officer in particular communities had a card that had the number to call and how to explain it to parents, because you want law enforcement to be your partners within the context of the work. Ongoing communication with those law enforcement teams is important as well. So that's how it was managed in New Jersey.
Thanks, Liz. Ann?
In Nevada, we're still trying to figure that out. So we have law enforcement at the table in conversations with us, but we are still working on that piece here in Nevada.
That's fair. So, Ann, while we have you, Andrew Macaluso really likes what he sees about VC, and he's wondering, are there any issues such as clients experiencing paranoia while using VC?
So VC is run out of our rules, and I have not heard that from our rural manager that there are any issues like that. In fact, families are finding it a great tool to be able to connect with services. So we haven't seen that yet, or I haven't heard about it yet anyway. But I can certainly ask that question to my rural manager, and if there are issues, get back to this group.
That'd be great. Thank you, Ann. We also had a question from Robin Henderson, and she's interested in knowing how many calls come in on a typical day. And that was for you, Ann.
Depends on the day. So like that trend that Liz had, we also see dips on the weekends and in the summer months and when school is out of session. So we can have anywhere statewide from a dozen calls to several dozen calls in a day. Not all of those end up in responses, though. So some of them could be that seeking of information, seeking of resources calls. We get a lot of calls for adults, actually. There's not a good, robust adult crisis response system, mobile response system in Nevada, especially in Clark County, which is interesting because we're the biggest part of Nevada. So we do get a lot of calls for adults as well. So we get a lot of calls. In terms of responses, those can be anywhere from just a small handful in a day statewide to a couple, a dozen or more statewide.
That's great. Thank you, Ann, for sharing that. We did have a response or another comment from Prel. He said thank you for responding to that. Virginia is considering police intervention to be part of the mobile response, and he's against that, so thank you so much. While we're waiting for some other questions, we did have a comment from Christine Cruz, who had to leave and jump onto another meeting. She talked about their system of care counties in their catchment area are using grant monies to implement common rooms in elementary schools, and that reduces the need for crisis response in the school system and school settings. Liz, I know in New Jersey they've used similar rooms as part of the Nurtured Heart rollout. Have you seen other uses, either one of you, of this technique?
I have seen it direct in the schools, in particular schools that I've worked with in New Jersey, and they're really powerful place for children to reset and get a minute to breathe and then re-engage in their classroom. And the best part about calming rooms is that they're peaceful places. They're not places that children would find scary, or so it's not a restraint kind of world. It's I need a minute to take a break because this is too much, or whatever. And they're very, very successful. They're also successful in inpatient units, and they're successful in residential interventions as well.
That's helpful. Thank you. Anne, are you seeing any use in Nevada?
I have not seen those in use in Nevada in the schools. I have not. I do have a calm room for my staff, however, where I have put bean bags and low lighting and a refrigerator with water and some snacks and things like that for staff to be able to come to if they need to take a step away, if they need a break, if they need to re-energize. There's some yoga mats in there. There's a fuzzy carpet that feels great on your feet. And I did that because the way we have them situated in terms of their offices, nobody has any private space because they're out in the field so much. So we really wanted to create spaces where staff were able to go and decompress and have that moment to step away and recharge and focus themselves again before they had to go back out. So some days are pretty hectic for them, and we wanted to provide that for them.
That's such a great technique, too, or intervention. You've just always got to keep on the forefront compassion, fatigue, and what our work does to our workforce. And you talked about being able to sustain the first rollout of your mobile response and stabilization through future funding. Can you talk a little bit about, it's always hard to build that chip, right, and collect the data, and then be able to show reinvestment, the worth of return on investment to sustain something. So can you talk a little bit about how you manage rolling out, collecting data, and turning it into a true score?
Well, I really did build the ship while I was sailing it. So we started with 5 positions that we begged, borrowed, and stole from other programs within my division, and had to expand very rapidly. So those 5 positions, we had 2 teams, 1 shift in Las Vegas. And within a year, we had tripled our staff in Las Vegas and added mobile response in Reno. And then the roles came on shortly after that. So it was, for us, less about having to prove the data, although they did ask for it and we were collecting it, but a lot about community outcry and the community voices of, we like this, we want more. And so as our supporters and our champions were coming on board and really making that noise for us to expand, and then we were able to show with numbers of calls and responses, and we were able to show our hospital diversion rate. So we were able to give feedback to administration and to the legislature that of all the kids that we see, 85% of them we're able to stabilize and keep them in their communities and at their schools and with their families, and that was really important. And then we just got very lucky, I think, with the Healthy Nevada Tobacco settlement dollars, and those that we continue to get those over time.
Great, thank you. And the questions are coming in now. The next one is from, I'm sorry I lost who it's from, but could you speak about how you address issues related to confidentiality, HIPAA, and electronic health records when involving multiple system partners?
Liz, do you want to go
Sure,
first?
this is Liz. Yeah, sure, absolutely. So the way that we designed it in New Jersey, first of all, during the first call, there's consent, right? Consent given for the for the team to actually arrive at the parent's house and the guardian's house, wherever they're going to meet, and then actually real consent form, the forms themselves are actually completed at that time. But the system is designed with an electronic health record that allows for all the partners to communicate together around what's happening. It's part of the consent that gets signed. It's part of the agreement in terms of how that is. And it's really important to understand that the electronic health record there's a firewall between who has access to that information. As an example, the Children's System of Care sits under the Department of Children and Families in New Jersey. That includes child welfare. Child welfare has no access to that record. They actually only get access to particular things when they come to the table as part of teams. So there are ways to really think about HIPAA and who should have information and when they should have information and how it's communicated. How do you build a hierarchy within the electronic record for everyone to communicate together? I'm happy to have more in-depth conversation with folks who are specifically interested because it may need some attention specific to your community.
Thank you, Liz. So Dan, that was Dan Toma that asked that question. So Dan, just let us know if you'd like some further follow-up. And Anne, did you have anything to add?
Just that our system looks much different in that our electronic medical record is specific to DCFS, so we don't open it up to anybody else. And so any information that we share, any records or any assessments, we do have to have the release signed by the guardian.
Great, thank you. And Dan says that was helpful, so thank you. Let's go back to Andrew Macaluso. He's wondering whether or not there's registered nurses on the team in case there's medical issues.
So this is Liz. No, there's not. We haven't encountered medical issues when we arrive, though. So that hasn't been an issue. There may be children who have chronic medical conditions. We may learn about those chronic medical conditions on the first visit, and that will be taken into consideration on the next steps of who and how we connect with and making sure that that child has a coordinated plan. As a quick example, mobile response might go out, recognize the challenges, work on communication, build a crisis plan, but recognize the chronic medical condition might be part of the concern and connect the youth with a behavioral health home in New Jersey, which means that they get connected with a wraparound team that would have a nurse and a wellness coach connected to it. So that's some of how it gets integrated and gets worked out together.
Thank you, Liz. Anne?
We do not have nurses on staff here either. So ours looks very similar to what Liz described in terms of identifying those and connecting with the resources.
Yep. Very helpful. Thank you. And so let's go back. Proud Growth has, I think, the $1 million question here. How do you ensure you always have staff ready to respond within an hour, Anne? And are assessors available in shifts? How long are those shifts? And how many are available at a time?
Yep. So this has been something that we have figured out a little bit over time and are continuing to always to look at and change. So what we looked at when we started creating schedules during our expansion is when more are calls coming in. So that was a data point that we were able to collect. And so we know when the calls are coming in and staff more heavily during those periods, which is, of course, after school and evening hours. So what we have done is created a variety of schedules. Some are 8 to 5 Monday through Friday. Some are working for 10 shifts Wednesday through Saturday, Sunday through Wednesday. We have people that work 1 to 10, 2 to 11, so you get where I'm going with that. So our schedules are kind of all over the place in terms of what we have created to meet that need. If we can't, sometimes we do have to move stabilization appointments. If too many responses come in, then we work with the family on that, but that doesn't happen very often, and so we have cross-trained some of our outpatient clinicians to be able to do the mobile work, and on days when we're particularly busy, we may call on them if they don't have appointments, or if it's after their shift, they might be willing to come in and do a response for some overtime for us. All of the supervisors are able to go out into the field, and then we'll kick to a supervisor who might not have been the designated supervisor for calls that day to take over the calls while that supervisor dispatches. So we have a variety of things that we have done. Our rural, who does telehealth for us, has picked up some of our urban calls if they've needed to. If one of the regions has been completely overwhelmed with calls, they're able to connect by telehealth for us on occasion as well. So we've pieced it together as we've moved along.
That's great. So data and cross-training are the
Correct.
magic ingredients.
Yep.
And Liz mentioned in New Jersey they saw a dip in the summer months. Did you see the same in Nevada?
We do.
Okay.
Summer months, school holidays, vacations like Christmas break and spring break, things like that, we do see a dip as well. We see a spike on Tuesdays and Wednesdays. We're not quite sure why, but we get a lot more calls coming in on Tuesday and Wednesday, so we know that's typically our highest volume days. Oh, the other thing we did, by the way, is we blocked out response blocks for clinicians. So during this 4-hour period, for example, this would be your response block, so you cannot schedule any stabilizations during that time on that particular day, so that we always had somebody that we can dispatch on a response. That was one of the other things that we've done recently.
That's great. Great strategy. Liz, did you have anything to add?
No. Ann's got a lot of solutions in New Jersey.
I have more so Jessica Wood asked, are contracts funded by fee-for-service structure, or is the mobile component cost settled or rate?
So I could start. So in New Jersey, it's a Medicaid reimbursed service. It's billed through a fee-for-service model. They get 2 different rates. So the first rate would be for the 72-hour period, is an assessment rate that they get. And then for the 8 weeks of stabilization, they bill actually in 15-minute increments in a targeted case management type of model, because that's the lever within Medicaid that they use. I can tell you that we have shifted the rates over time to ensure that mobile response isn't losing money on it, because we want the organizations who are doing the work to actually always feel, to be able to actually continue to grow and move as they need to. So I don't have the rates on me, but I can certainly get a hold of them for you.
Thank you. Ann?
Yep, so our rate structure is also written into Medicaid. It's a reimbursable service. So for the first 3 days, we can bill up to 4 hours a day for 3 days for crisis response in a team. After that, we shift into more traditional codes like family therapy codes, in-home family therapy, in-home individual or individual codes. And then we have the ability to build targeted case management on top of that as a state agency. So we have the case managers, those PCWs, the bachelor's levels, that is part of our team, who are doing all of that connecting, linking work. They can bill for those pieces as well, separately from the therapy piece after that first 72 hours.
Great, thank you.
This is Liz. Can I just add one more component to that? I talk about Medicaid and the billing happening within Medicaid. In New Jersey, every child, whether they have Medicaid or not, is billed as if they have Medicaid. So children who don't have Medicaid are billed through a Medicaid look-alike number. So the team that's providing mobile response and stabilization gets paid whether the child has Medicaid or not in the same billing process. I just wanted to have clarity around that.
Insurance blind component is great. So the next question is from Teresa Welsh, and she's interested in knowing how long a team stays with a child after a crisis for stabilization. Is there a certain amount of months?
So
wants to take
so
that
this
one.
is, yeah, so I'll start. So like I said, it's a 72-hour initial response, and then they determine if they need more. Then it's up to 8 weeks of stabilization and no more than 8 weeks. So that's the max. In New Jersey, if they feel like the youth and family need more, they actually connect to intensive care coordination using high-fidelity wraparound as its practice model. And the mobile response team can do that pretty easily. They can make the connection for that service to go into place.
Thank you.
And so in Nevada, we can stay involved up to 45 days. That is a little bit of a loose ending in that it's not contractual or anything like that. So if we have kids that need to stay past that, they're staffed with me as the program manager, and I can give that exemption. It doesn't happen very often where kids need to stay. And it might be that we just need another week or two until we can get them into their appointment because they have private insurance and we couldn't find a provider that was available to them, for example, and we don't want to have that gap. So it's things like that where we might have to stay in a little bit longer until we can do that warm handoff.
Great. Thank you. So Dan Ani did put in the chat box, and I think he sums it up very well for all of us. Thank you to both of our presenters. Great information, and so good to see services meeting children and their families in their own environment. I do not believe we have any other questions.
So this is Liz. I'm wondering if before we close, if you could take a minute to talk about some of the resources at the TA network on mobile crisis.
Yes. Sure, would love to. So thank you, Beth. So there's been a team working on mobile response and stabilization statewide, and is a faculty member on that, and so am I, and we do work in bringing all of our resources together. So there is a link within the Institute's website. So if you go to the Institute for Innovation and Implementation, there is a mobile response in the national work. There are a ton of resources, including things like the state plan amendments that folks put in for Medicaid, and the RFPs that went out, to find providers. There's clinical criteria and return on investment information. So there's really a wealth of information in that link. On top of that, we have ongoing affinity calls that are publicized in the TA Telegram on a regular basis. We'll have a topical call that will discuss it. It looks like a webinar in which we'll have two experts present on particular topics. The last one was on adult versus children's models, and then we put together some slides, and we also open the lines and take calls, take questions around implementation. So if you're close to implementation, interested in implementation, you're more than welcome to call in on any of the affinity calls. All of the past affinity calls are all in that resource link that we just talked about and available on the website. And I'm also happy to connect you to other folks who are doing this work around the country. We're very fortunate to have a robust team of people who are thinking about this work on a pretty regular basis.
Thank you. So to wrap up, again, we'd like to ask you to hang in with us just for a couple more minutes and use the link that will pop up to complete this very brief evaluation. And I'd like to add my thanks to Denise's, to Liz and Ann, for their outstanding work on this session. I think they've left you with a lot of practical strategies that you can apply in your states and communities. And as Liz said, there are a lot of resources that you can find on ideas at the Institutes and through the TA Network website. Thank you also to Tiara Brown from the TA Network for handling all of the technical aspects of this session. And as always, she does it so well. And one last plug for the next Learning Community meeting on April 19th on co-occurring substance use and mental health disorders. So thanks to all of you for joining us today, and the evaluation will come up right now.